Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of endometriosis. Dr. Travis Brown, I have a vague recollection that we're returning to a topic, that being endometriosis. I feel for many sufferers because it does stay a long time until you have good management around it. So am I right?
You are. We did this in This Pathological Life. So we did it. It was I think it was the tragedy of the wandering uterus, because this was the history. This was the horrible history of pretty much women's health and pelvic pain, abdominal pain, about how it was managed or not managed or ignored. And it was sort of associated with hysteria. That's why the uterus moving around.
That's right.
This was the history of it. And it was a very hard history.
It was. But today the focus is on clinicians.
It is. So previously we've discussed probably endometriosis from a pathological perspective. So if you want to go back and listen, we had a pathologist, Dr.
And we can put the link in the show notes, by the way. People can go back and read that. Yeah.
That's right. This was one of those areas that needs to come back to, because it's such a complex area. It's hard, and it's difficult for patients, it's difficult for clinicians, and to really get your mind around. Now, I need to say thank you at the top for Dr. Alicia McCrow. She has helped us pull this together. She's one of our guests today and really pull this episode together. So I really want to say thank you. And if we look at endometriosis, in a different perspective, one of the hardest areas to study, it will sound a bit strange, but one of the hardest areas to study is embryology. Now, embryology is pretty much exactly, what do you think embryology is?
Embryos?
Yeah. So the study of how an embryo develops pretty much from day zero to become a human being. And this is, two half cells effectively coming together to make everything that we are. And when you're looking at it, you come about 3 layers. This is called endoderm, mesoderm, ectoderm. And these are the 3 layers that the entire body is derived from. And look, it's a really hard area because it's almost academic. It's abstract. How does a liver be produced? How does a stomach be produced? How does the brain be produced? And you have all these different progenitor cells. You have to have a whole bunch of signals, which we don't fully understand, but somehow one cell can either differentiate into a brain cell, into a skin cell, into a kidney cell.
Isn't it fascinating? This action is replicated millions of times every day on this planet.
And the amazing thing about it is how often it goes right.
Yes.
There are millions of different signals that to try and sort of force you to go down one path as opposed to other. I mean, we get this coming out, and you do have occasional congenital diseases and malformations, and we deal with that very well in medicine. We can detect them early. I mean, there's even intrauterine surgery happening where they can fix things. It's just an incredible and really unbelievable time. And the amazing thing is how often it goes right, and that's the thing. But there are occasions where you get things that occur in different areas that shouldn't. And we call that ectopic tissue. So you can get tissue that lives outside the either cavity where it's meant to be or the area. So you can get things like you can get lung tissue outside the thorax. And so you can get things like ectopic thyroid tissue, liver, pancreas, even brain tissue outside of where it's meant to be. And it's in most part, it may not be a problem at all. It's just when something gets cut out, we go, oh, that's a bit odd. When you look under the microscope, it looks like neural tissue in that area. And so one of the most interesting specimens that you'll come across in histopathology in ovary. It's called a dermoid or a mature teratoma. And this is one of the most common tumours that young women get, and it's benign, between the ages of 10 and 30. And it can be large. It can be really big. Like it can be 5-10 kilograms of a huge dermoid cyst coming out of a woman's abdomen and the pelvis. And it has in it all sorts of tissue. So things like it's common to have hair in it. It's common to have skin, keratin, fat. And then it can have all sorts of other different tissue in it, such as thyroid, bony tissue, even teeth, when you're cutting through it. And so this is a large cystic structure that just has different sorts of tissue. And if it becomes immature, that's when it's actually a problem, because that can be a precursor or can cause malignancy. And so they get removed more often than not. They're completely benign, but you've gotten rid of this huge mass out of someone's pelvis. And so this is where we sort of touch into endometriosis. And this is the definition is the presence of endometrial tissue, which is from the inner lining of the uterus that exists outside the uterine cavity. And now there's a whole bunch of theories as to why this occurs. One of the theories is the regurgitation theory. And so this is believed to be that there's some retrograde flow of menstrual endometrium that goes back in through the fallopian tube and comes out into the abdomen and then causes that tissue to adhere elsewhere and live on through the cycle. You have this benign metastasis theory that somehow this endometrium seeds from the uterus either through the blood vessels or lymphatics to other areas of the body. And you have this metaplastic theory where the linings of other organs undergo, for whatever reason, they get messages to differentiate into endometrial tissue and then causes the issues that it does. Or the fourth main one is this extrauterine stem cells come from the bone marrow and then just adhere somewhere else in the abdomen and become endometrial. So there's a whole bunch of theories. We don't know why it occurs. We know that none of those theories have been proven or disproven. It's just we know that people get it because some people will have retrograde flow, but they won't get endometriosis. So why do people? Again, the theories. Again, we're not great at explaining why something that we know it happens.
Isn't it fascinating? Because you made the comment at the beginning, it's amazing how often this goes right. And then you hear where things have gone wrong, sometimes presenting themselves in ways that need action, and sometimes the body copes. It's like we're walking margins of error.
Well, I'm learning we're actually, as a people, we find that we think that normal, complete health is for everyone. It's actually, as soon as you start to talk to someone, you realize how many ailments we actually have. Living with disease is actually the norm as opposed to not. But look, this is a real challenge for doctors and for healthcare professionals. First of all, for recognizing it, and second of all, for managing it. And so this is where the other problem is the whole range of symptoms can be variable, meaning it can go from anywhere from either asymptomatic or mild symptoms to very severe and debilitating symptoms. And it still comes under this same endometriosis banner. And so this complex issue is something that we've got a few guests today to help us understand and highlight important things for doctors and for patients to be aware of. And looking at it from that perspective, how do general practitioners manage it? How do specialists manage it?
Dr. Alicia Macro is a general practitioner and owner of Thrive Family Practice in Adelaide. She has broad interests across primary care, particularly in the concepts of lifestyle medicine, which prioritises management of lifestyle factors in chronic disease, especially food, movement, sleep, stress and social connection. Alicia has undertaken further study in dermatology and skin cancer, women's health, immunisation, sexual health, menopause and contraception. Alicia also holds a graduate diploma in scientific communication. And Thrive Family Practice is one of 22 clinics around Australia that receive government funding to assist patients with the pelvic pain and endometriosis. Dr. Macro is our guest on This Medical Life. Alicia, welcome.
You. Great to be here.
It's lovely having you. And I want to start broadly. This is such a complex area. Let's begin. How does a general practitioner approach something like pelvic pain?
I think one of the things that I've learned since I've been focusing heavily in this area is probably the most important thing a GP needs to do is actually start zooming out, because a patient is never going to come into your consult room and tell you they've got persistent pelvic pain. You know, they'll come in and say that they have stabbing pains in their legs or in their back or in their rectum. They might complain of recurrent urinary tract infections. They might complain of pain during sex, but they also might not. And I guess the key one is that they might come in complaining of heavy and or painful periods. And I think that is helpful to take that as a flag to start zooming out and thinking about all of the other pieces of the pelvis that might be involved. I think one of the things that I've noticed most is that pelvic pain gets missed because people are thinking about just dealing about what's coming in front of them rather than thinking about, is this part of a bigger picture? And as soon as you start zooming out and thinking about the bigger picture, a lot of other things start slotting into place quite quickly.
Is it something that should be triggered initially with the initial consultation, or someone just keeps on returning with vague symptoms that you mentioned?
I think that it's probably helpful to, I mean, obviously the patient wants to deal with whatever they've come in for that day. And if it is heavy, painful periods, I think need to start thinking about that straight away and take a good history, a menstrual history and so forth. And then perhaps, you know, think about what management might involve, but perhaps flag with the patient that often when we see this, we see other things coming in along with it as well in a pattern. And you know, often in general practice, you know, your patient might be booked for a 10 or 15-minute appointment, and that might not even be the only thing they've come in to discuss with you on that day. And I do think it's a good opportunity to sort of invite them to come back and talk just about, you know, what's happening in their pelvis. Otherwise, just miss the opportunity over time. And sometimes it's not until you've seen someone a number of times before you start thinking about, you know, what else is going on here.
When we're looking at pelvic, there is something such as pelvic floor dysfunction. Is this contributing to pelvic pain at all?
I think so. And I think that's a really important factor that GPs need to be thinking about when they're seeing someone coming in with any kind of pelvic pain, whether that's pain during sex, whether it's stabby pains in the back or the legs, even if it's heavy periods, to actually start thinking about what's going on with their pelvic floor. Because anyone who's had a history of problems with their pelvis or bad periods over a number of years, in my experience, is almost certainly going to have something going on with their pelvic floor. And the way I explain it to patients is a bit like if you roll your ankle, the pain doesn't necessarily all come from a ligament damage or so forth. Often it's coming from the muscle spasm around that injury. Same with lower back pain often. So your pelvic floor is a big bulk of muscles, and it can really only do two things. It can either relax or it can contract. And if you're in a situation where, you know, this pelvic floor is used to being in a sort of danger situation, it's going to start contracting and spasming, and often it will continue to cause pain even if whatever started causing the pain gets better over time. And I think if GPs and others aren't thinking about pelvic floor in pelvic pain, they're going to be missing a big part of the picture, and also an easy way to start getting these people better as well.
The challenging thing for GPs is just the broad range of patient ages you're dealing with. I mean, when do you start to ask questions? What age do you start asking about pelvic issues?
I mean, I think you could really start talking at any time between sort of menarche all the way through the life cycle. So I've seen women or girls in their early teens. And I've seen women in their 70s come in to see us in our pelvic pain clinic who've still got pelvic pain. And obviously, a 70-year-old woman, unless she's on HRT, there's not a hormonal component to her pain, but there's, a series of problems that's been set in motion and has never been stopped. And so anyone, and interestingly with the young girls, if you start looking back further, often they'll be complaining of abdominal pain or pelvic pain before they get their first period. That's obviously, not able to put two and two together until a pattern starts emerging later. So I don't think there's a time that's too early to start talking about this stuff and start thinking about it and start talking to parents about it as well.
Do psychosocial factors contribute to pelvic pain at all?
Massive. And I'm sure it's the same with any other type of pain. So again, I talked earlier on about zooming out, and one of the things I say to my patients is we're not just a pelvis. So what's happening in the rest of your body and in the rest of your life is going to have an impact on the way that you experience your pain. And so certainly what I see is the more chaotic a person's life, the more likely they are to be having worse and more persistent pain over time. So job insecurity, housing insecurity, a history of neglect, abuse, chaotic upbringings, difficult relationships, domestic violence, so many things, intergenerational trauma, medical trauma, sexual trauma, all of those things are going to impact someone's experience of pain, and pelvic pain in particular. And again, we need to be seeing these women and people as a whole person to start thinking about, what's the whole context. And how is that contributing to their pain? And I do think that the unfortunate factor about pelvic pain is that not only do those factors make it worse, but having pelvic pain also predisposes you to having further social problems. You start missing out on social activities, you start having sick days from work, your job starts becoming insecure, you have relationship issues, which again can just feed straight back into the pelvic pain problem again. And people get stuck in this loop, and it's awful and it's tragic.
What is your approach to a patient with chronic pelvic pain?
I think the most important is to make time. And I know that is hard for GPs. We're lucky that we are aware of this and we have some resources to tackle pelvic pain as a big issue and a big appointment. So if I start seeing someone who I think is someone who's suffering from persistent pelvic pain, I'll invite them back and we get them in for an hour, and often I go over. Sometimes we're 75, 90 minutes with a patient, and most of that's just going to be taking their history and taking a really structured history around not just their periods and their reproductive history, their social history, but also thinking about their bowels, also thinking about previous surgeries, also thinking about their bladder, their vulva, and their pelvic floor. If you can get that whole picture together, then the management often falls out quite easily. Like GPs are good at managing complex problems. We do it every day. And I think the thing that we find most difficult is, in this case, is just having some time and space to think through all the different issues and have a think about how those things are interrelating with each other.
Now, we're talking mainly about endometriosis as a topic here, and the lead-in. So when should endometriosis come on the differential diagnosis for patients with pelvic pain?
I think we need to have a low threshold for thinking about endometriosis in people with difficult periods and with associated pelvic pain. So we know that the average time to diagnosis is something like 7 years for most women, and many of the women that I've seen are probably longer. And many of the women that I see will report that over time they've been told to suck it up, or it's a woman's lot, or, periods are painful, you should take some Nurofen. And that might be from their parents, it might be from their doctors, it might be from their employers as well. And so people can go on a long time without having anyone think about, is this something that is more than just bad periods? And I think we do need to think about this more systemically when we're seeing women, because we know that there's a lot of undiagnosed endometriosis out there. I guess the point that I would make, though, is that Endometriosis is one sensitizing factor in the development of pelvic pain, but not the only one. So you could certainly meet somebody who's got chronic pelvic pain who doesn't have endometriosis. It doesn't mean that their pelvic pain is not valid or is not real, but they might have another sensitizing factor, and that might have been trauma, or it might have been chronic urinary tract infections, or it might have been surgical scarring or so forth. So, or a pelvic infection that's lasted over a period of time. So I think there's two questions. I think the first one is this chronic pelvic pain? And the second one is, well, what do we think is driving that pelvic pain? But then the management for both is similar regardless.
What are some of the common presenting symptoms for patients with endometriosis?
So common presenting symptoms of endometriosis can be really any of the things that we've talked about. So I guess the big one is going to be heavy, painful periods, pain during sex, but also other things. People having, chronic bladder issues, chronic bladder pain can also be a presenting symptom as well. And chronic, I guess, musculoskeletal pain, stabby pains in the legs or back is probably a later symptom. I think by the time that starts to present, somebody's had probably pelvic pain and endometriosis for a period of time. I mean, I think if we were really thinking about bad periods in the teenagers that we see and start treating that, we might have a better chance of stopping some of those people progressing into persistent pelvic pain.
Alicia, they're the common presenting symptoms. Are there any uncommon ones?
I think if you start, and I think a lot of us GPs do think in terms of pattern recognition, I think if you start in terms of thinking about this person's coming in with chronic constipation, chronic pelvic floor pain, pain during sex, bad periods, I think most people are going to come in with a constellation of those symptoms. The other one is infertility, I think, needs to be thought about because, of course, not everybody with endometriosis does develop chronic pelvic pain, and some people will only get picked up when they have had a period of trying to conceive and come in for some further assistance at that point. Something like 30 to 60% of people with, quote unquote, unexplained infertility have underlying endometriosis. So that would be the other place where we would start needing to think about endometriosis as well.
My head's a little bit overwhelmed by just the complexities that we're getting into here. Let us take a very brief pause and regroup and come back and have a look at the multidisciplinary approach that you take at Thrive. Let's continue now with Dr. Alicia Macro. And Alicia, as I mentioned just before we had a breather, what is this multidisciplinary team management approach that you take to pelvic pain and endometriosis?
What we do here at Thrive is we do really try hard to both zoom in and zoom out. So what's happening with pelvic pain is happening at the histological, pathological, cellular level, as well as all the way through to what's happening in someone's life in terms of their work and their career and their partnerships and their housing and so forth. As I said, once you've got a really good picture of what's happening with that person, all the way through their bio, psycho, and social paradigms of their life, often management kind of falls out of that quite easily. And one of the things I like saying to the women that I see is that this stuff is complex, but with complexity comes opportunity. And so if you've got a very complex web of problems going on, it also means that any threads of that web could be pulled out to start untangling this big problem. So however, with a complex problem, also needs a multifaceted solution. And so that's one of the things that we've worked really hard to implement here, is to try quite hard to bring a team together so that team is working in concert with the patient in a way that's been coordinated and communicated well. It's been certainly well studied and reported that fragmentation of care in these women is a big problem. So they might have, by the time they come and see me, they might have seen 2 or 3 different gynecologists. They might have seen a urologist. They've probably had a colonoscopy. They may or may not have seen a number of alternative healthcare providers and a number of GPs as well. And the theme is that it's frustrating and hard to get anywhere when all of these different people that you're seeing aren't kind of talking together and thinking about the big picture together. And so we've brought together a very multifaceted team with gynecologists, we've got a gastroenterologist, we've got a couple of colorectal surgeons that we can call on if we need to, pelvic physio, dietitian, psychologist, exercise physiologists, and we try really hard to work together. So we'll have a regular interdisciplinary team meeting every month or so, with permission, talk through the most complex cases, not unlike happens in the cancer care, and then advice is sought, and then the patients can be led through an appropriate treatment. And everybody's treatment's going to be slightly different, depending on what their goals are and also what their primary problems are.
So you've put together essentially an endometriosis action plan. What can you tell us about this?
So we're still developing it, but what we've done is we've looked at the body of evidence around the asthma action plan, and we've adapted it to use in pelvic pain. As the GPs listening will know, the asthma action plan is all about identifying someone with asthma and thinking really hard about what are the day-to-day sort of preventative measures that they can be undertaking that reduce the risk of their flaring up and reduce the severity of a flare-up. And I do say to people, the people who have the managed asthma will hit a thunderstorm and be okay. The people who aren't taking the preventers and aren't doing their exercise and so forth are going to could hit a thunderstorm and have a big asthma attack. And pelvic pain is not dissimilar. If we can think about and manage the day-to-day boring stuff, what's happening with your bowels, what are we doing about your pelvic floor, what are we eating, what's happening in your life, and how are we dealing with some of those stressors, dealing with that as the sort of when you're well part of the asthma action plan, and then also talking to them about, can you identify what it looks like when you're becoming unwell? Again, just like we do in the asthma action plan, what does it look like for you when you're starting to become unwell, and what are we going to do? A lot of the women that we see, they wait until they've got severe pain because they try and be tough and they try and be strong and they don't take anything, and they don't, they're so sick of thinking and dealing with it that they don't want to do anything from day to day to help keep them well, which means that they keep flaring. And so we found it really successful to help them focus on the day-to-day things that keep them well, and also that simple management around early flare-ups, to think about, simple pain relief, and also posturing, positioning, exercise, dietary factors, other supplements, so forth, that can be helpful, which means that they don't get down into the red section very often, that flare-up part. Where they're traditionally going to be calling an ambulance or ending up in the emergency department or taking opiates. It's wonderful to see the feedback around, I've got all of these opiate prescriptions that have been given by others, not by myself, and I'm actually getting to the point where I can put them away now because I don't need it. And that's been wonderful to see. I mean, that's life-changing for these women.
Alicia, you mentioned exercise physiology earlier, and I'm curious about the role of movement and exercise as a therapy here, especially having lived with a former partner who endured endometriosis. It seems counterintuitive.
It does sound counterintuitive, but so helpful and important for a couple of reasons. I mean, the simplest one is that the role of the pelvic floor in pelvic pain is super important, and so a very well-informed, very well-trained pelvic physiotherapist can be worth their weight in gold here. We use a very well-informed, very well-trained, trauma-informed exercise physiologist to play a similar role. And again, working with these women over time, one of the themes that we see is that they stop moving. I ask them, what do you do when you have a flare-up? I curl up, I call in sick, or I don't go to school. I curl up in a ball and I put a heat bag on and I wait for it to get better. But if you've got a spasming bulk of muscle there that's contributing to your pain, if you can allow or help these women or show these women how to, rather than curling up, to actually start opening up again, even doing that can relieve what starts building up to be a bad flare. One of the things that Cherie says, our exercise physiologist that we work with, Cherie Noble, is that position, that curled up in the fetal position in bed or on the couch, is always available to you. But could we try some other things first? Could we look at, doing this child's pose? Could we look at some of the other, pelvic? I don't like the word stretch because it makes it feel like something you do before you go do a run. It's sort of more like a pose. Can you get comfortable in a position that's opening up your pelvic floor? And see how that feels over time. And that can help in a flare, but it's also helpful, in the sort of day-to-day stuff around, what can we do to start chilling out this bulk of muscle that's causing you problems? And then often, interestingly, I always talk to people about what their goals are when they come and see us, and getting back to exercise is actually one of the top things that people will say. So, and again, it's like, are you on a down spiral or are you on an up spiral? Because we know that there's benefits to exercising for your overall well-being and your musculoskeletal health and a million other things. We know that there's benefit of spending time in nature, for example. It's not uncommon for someone to say, I want to get back to hiking again because I can't do that anymore. And so there's actually multiple benefits from the very small things about what are you going to do when you're in lots of pain through to what do you want your life to look like if we can make this horrible problem get a bit smaller for you.
In some of your information, there was something called NEI Assemble. Can you tell us about that?
What we use here is a framework for understanding and communicating some information about persistent pain to our patient group. I would say all of them have been told, the ones who are significantly disabled with pelvic pain have been told that their pain isn't real, or it's in their head, or they're making it up, or whatever. Not always by the medical community, but that's the sort of feedback that they're getting. And the medical community are also, I think, trying to have conversations around persistent pain, but it's easy for that to go badly. It's easy for that to be interpreted as the doctor thinks that the pain's in my head. So I've done some training, and my exercise physiologist has done some training, and we've sort of been through some NOI group training, which is I don't know if you're familiar with Lorimer Mosley, who's a physiotherapist who's really pioneered a lot of progressive thinking about persistent pain. But one of the frameworks that was presented to us was this idea of the NEI ensemble. So ensemble being there's a number of characters that are all working together, N being for nervous system, E being for endocrine or hormone system, and I being for immune system, and particularly the role of inflammation. And it's helpful to think about this as a 3-part system that is working together in real time that can either increase the pain experience or decrease the pain experience. So things that increase your fight, flight, freeze drive, like being trauma, having difficult relationships, having an unstable upbringing, so forth, can set off the NEI ensemble to increase the sense of persistent pain. So, for example, that's likely to increase your cortisol level and your adrenaline. And also, there's been research shown that can also increase inflammation as well. And so increased inflammation can also set off the nervous system. Increased inflammation can also increase stress hormones. And so each of these parts of the NEI ensemble are often working together to increase the pain experience. And we often get women together to think about what are their different facets of their issues with their pelvic pain and where does it fit into this NEI ensemble? And then also start to reverse it and sort of say, okay, where are the bits that we can start to make this better from the NEI ensemble? So you can imagine if I say to someone who's completely flawed with their pain, their life is, an awful mess of problems, and say to them, we need to think about doing some breathing exercise and meditation. And they're going to roll their eyes at me and say, can you not? Because, I've been to ED 3 times in the last 3 months, and I've seen 10 different doctors, and I've had 10 surgeries and so forth. But if we can do some regular interventions that reduce that fight-flight drive, and we know that some regular breathing activities, using the diaphragm and breathing, can help to tip your nervous system away from fight, flight, freeze back to rest and digest. And actually, even something as simple as that can actually tip that NEI ensemble back the other way towards less pain. And even things like simple analgesia or using anti-inflammatories where we can that reduces inflammation. If there's less inflammation, there's less drive to the nervous system, there's less stress hormones and so forth. And so a lot of the simple things that we do, if you think of it within that NEI ensemble, it provides like a helpful framework for both practitioner and patient to think about how can they help their pain get better. And other than finding opportunities, the other thing that I really like about it is that, to me, it's actually a really compassionate way to think about talking to someone about pain. Now, I had a 21-year-old that I saw who had been told that the pain was in her brain and she needed to change her brain. That was the advice that she'd had. And I know that that was well-meaning advice, but that doesn't really help her to understand. And again, it makes her take it on as, this is my fault, I'm making it up, I'm, malingering or whatever it is. Whereas if you can say your nervous system's involved, your endocrine or hormone system involved, and your immune system is involved, most of this is not within your conscious control, but there are still opportunities there for you to start improving your pain experience, I think is both validating and empowering for these women.
One thing I love about the NEI ensemble concept is both you and the patient play the role of the conductor of this ensemble, and you can note, we're going to work on the woodwind section this time, or I can hear that it's the brass. And it's a wonderful image to pull that together.
I'm clearly not as musical as you are, Steve, but I love that. I love that. And the other thing I like about being able to talk about these complex concepts in simple language is you get your patients or a non-medical person start coming back to you with their own interpretation of it. And once they can do that, then they get it. And then they actually take some of their power back, because it's very disempowering being stuck in this tangle of problem that they come in with. And so I love that. I love that. In fact, I'm going to steal that.
Do patients with endometriosis always have fertility issues?
I don't think so. And I don't think there's anything that boosts a person's fertility more than being told that they can't have children. So no. What I do say to the women that I see is that most women with pelvic pain and endometriosis who want to have children are going to be able to go on and have children. It's possible that it might take a bit longer, and it's possible that they might need a little bit more help. But fertility issues are certainly overrepresented in women with endometriosis.
Is there any useful strategies for general practitioners with endometriosis that they can prescribe, aside from the management plan, which is clearly a very useful multidisciplinary approach? Is there any strategies that are medical that would actually help with their management, such as the oral contraceptive pill or intrauterine device or anything like that?
So I guess strategy-wise, first one I don't think we've mentioned, but it would be amiss of us not to mention, just think about mimics. So make sure your patient doesn't also have celiac disease or inflammatory bowel disease or bowel cancer or other things. Like, think about the mimics first and rule those out, just like we do every day with other things. But yes, in terms of the management plan, menstrual suppression is what I call it, is a really helpful part of management for endometriosis. And many of the people that we see with chronic pelvic pain have tried a number of different things already, and it's just about A, trying to help them understand why it's important, and B, trying to find something that they feel comfortable with where they have sort of the least amount of side effects. Mirena or Kyleena or intrauterine devices can be really helpful. There's lots of different pills, of course, on the market that can be helpful in suppressing periods. I don't use the depot injection shot very much. It can affect bone density and also contribute to weight gain. But some people find it helpful and they use it and they are happy with it and so forth. So we go with it. But yes, menstrual suppression is probably one of the most critical parts of management. And I think if we're not doing that, we're not doing our patients a service. And then thinking about the other sort of key parts of the problem. So what are we doing about that patient's pelvic floor? Examining it for a start would be good. How increased tone is it and how sore is their pelvic floor? One tip that I've got for GPs that I've picked up that I find really helpful, even if you have a patient who's not comfortable having an internal examination, is actually just having a feel of their adductors. So set them up as if you're going to do an internal examination and have a have a feel of some muscles you don't expect to be sore, like their calves or so forth, and then palpate their adductors. And their adductors are always sore. And that's not even their pelvic floor. It's just their adductors are attached to their pelvic floor, to their pelvis, and they start getting sore too. Again, it's that protect mechanism, and that starts giving you a clue that this person's got some pelvic floor dysfunction. Almost all of these people have got some sort of bowel dysfunction, which is probably secondary to their pelvic floor dysfunction. And so thinking about and managing their constipation and their bloating, sometimes it's diarrhea, is really helpful. And I've seen young women in their 20s who are manually disimpacting. They've had this chronic severe constipation going on for so long they don't know what to do. And using a regular fibre supplement. So we like even just a, psyllium or Metamucil. We also like, there's one called K-Fibre that our patients seem to quite like that you can get online or at health food shops, which is made from the sugarcane fibre. And again, it's about what you're doing every day. It's about what works for you and doing it every day, and sorting that out can help with their bloating, and it can help with their constipation, and often they're getting sort of rectal pain as well. So that's important. And yeah, as I said, what are we doing about their pelvic floor? Do they need a care plan to go and see the pelvic physio? Do I know my local pelvic physio? Can I talk to them about it, and those sorts of things? And then there's other sort of simple strategies as well. So, depending on how much we want to go into it, there's different sort of pain relief options, like TENS machines, and there's all sorts of different interesting contraptions for more comfortable sex, for example. So there's just a bunch of things. And the other thing I think is finding some kind of pain relief that they can take over a number of days when they are starting to flare up that's appropriate for them, even if it's regular Panadol Osteo or a regular anti-inflammatory that they can take for that week. If they've got a period, if they've got a flare up, can be helpful as well. All of these things are really simple.
Who are the patients that need referral to a gynecologist?
I think there's two parts to that. If they come in and they feel like they haven't had an opportunity to see a gynecologist and they want to see one, then I think that's an excellent reason to refer to somebody. And the second place that I tend to refer is someone who is not getting better with the simple management that we've discussed. So we might give them, if they're happy to work with us initially for, say, 3 months, work together for 3 months, and most people are going to come back saying that they're feeling a lot better at the end of that 3 months. But the ones who aren't, I think that's a flag that they need further investigation and management. And I guess the third is those who are trying to get pregnant and having trouble getting pregnant if it's been a reasonable amount of time, depending on their age.
Alicia, a moment ago you gave very comprehensive set of tips for GPs, but we do like to finish off by asking, is there any final advice for doctors with patients presenting with endometriosis, pelvic pain, etc., or even for patients as well? What are some final things you'd like to leave for us?
The key thing, I think, is that it's been really well documented that there's significant barriers in place for these women to access a formal diagnosis of endometriosis. And that's getting better over time, but getting that formal diagnosis, for example, through a laparoscopy, is not always appropriate for everybody. If you've got a 15-year-old, it's not necessarily a path that we want to or need to go down. So endometriosis can be difficult to formally diagnose, but persistent pelvic pain is a cluster of problems that's going to be coming and seeing you regularly, day in, day out, and it's not hard to identify those people. And so identifying those people, looking at the whole picture and putting in some management as well as, ruling out some of those mimics is going to get them 80% of the way there. And then they can look forward on a formal diagnosis or formal treatment or more complex treatment further down the track if they need to. But you're going to do them a huge favour if you can pick it up and get on with it rather than kind of sitting around thinking, I wish we knew what was going on here.
Wow. Well, look, thank you so much for taking us through this. My takeaway is that amid the fragmented pathway that many patients are on, the application of some time is one way to bind this together so you can regroup to then move forward with a strategy in place. Dr. Alicia Macro, thank you so much for joining This Medical Life.
Thank you so much for having me.
We're being joined now by Associate Professor Susan Evans, who is a gynaecologist, laparoscopic surgeon and a specialist pain medicine physician from Adelaide. Associate Professor Evans is a Fellow of the Royal Australian and New Zealand College of Obstetricians and Gynaecologists, a Fellow of the Australian and New Zealand Faculty of Pain Medicine, Clinical Associate Professor of the University of Adelaide, Executive Chair of the Pelvic Pain Foundation of Australia, co-developer and medical educator for periods pain and endometriosis, the Pep Talk Schools program. And she's the founder and CEO of Alira Biotech, which is a biopharmaceutical company developing a novel intrauterine device to reduce pelvic pain in women. Associate Professor Evans is our guest on the This Medical Life podcast. Welcome, Susan.
Thank you very much for having me, Stephen. It's such a pleasure to talk about endometriosis and pelvic pain for your listeners at ClinPath.
Well, we have been talking about endometriosis right through this episode. Everyone knows what we're talking about, but it is useful to clarify what we actually mean. So what is endometriosis?
Yes, and that's such a good question because I think it means different things to different people. So actually, factually, endometriosis is lesions that look a lot like the endometrium if you look at them down a microscope, but are outside the uterus in places they shouldn't be. But that's actually a little simplistic. There's a few things. Firstly, they don't behave in the same way necessarily as endometrium, so there's a lot of similarities but also some differences. And probably more important to your listeners, when people use the word endometriosis, it's worthwhile thinking, are they talking about the lesions, the black things you might see in a woman's pelvis, or are they talking about the symptoms that they've come with? And people tend to merge them all together. They think it's all much of the same thing, but it's actually a little bit more complex than that. And it's worthwhile thinking, am I worried about this person's black spots or am I worried about this person's symptoms?
Now, being an expert in endometriosis, what's the most common question you get asked from doctors or patients?
I guess for me, because I tend to see the people that haven't had much luck with other treatments, I guess their major focus is to treat the pain. Many of them have already had any endometriosis lesions that they may have had removed or treated or something, but they're left with symptoms and a lower quality of life. So they're really coming to me because they actually want to sort out the other things, not just the black lesions.
Now, we have spoken to Dr. McCrow regarding about dealing with patients as they're being seen, or maybe they come to her after a course of not quite sure what it is, and they may be diagnosed for the first time with endometriosis. But when is the ideal time for a patient suspected of endometriosis to be referred to a gynecologist?
Well, I actually think that the really important time is early in their teens, not to go to the gynecologist, but to start learning about if their pain is normal, how all the symptoms fit together, simple things they can do to manage pain themselves, and when to look for help. And so I'm not saying that those people need a gynecologist. I'm saying that the recognition from an early age so that intervention can happen early, management of symptoms is what I mean by intervention, is the important thing. And of course, that's why we have our Periods, Pain and Endometriosis Schools program, the Pep Talk program, which started in South Australia, and South Australia can be very proud at how it's spread around Australia. So I think early recognition that this is a child at risk and that the symptoms are going to be managed early and education is going to start early is the most important thing. And then, of course, the person for them to see is an upskilled general practitioner. It's not a gynecologist. So much can be done in general practice to manage and assist these people to live lives with less pain before you need to consider referral to a gynecologist.
I would just like to underline how profound I think that answer was, because I'm sure there are many heartbreaking stories of women who have just assumed what they were experiencing was normal and have tolerated high pain through their lives for want of that extra knowledge and understanding.
Absolutely. So many of them say, look, why wasn't my pain taken notice of earlier? And it is a hard thing being a general practitioner with a lot of people coming in. And it's not everybody's thing. General practice covers so many areas. It's not reasonable for a general practitioner to have to be great at everything. But I think to take notice of when there is someone with pain and to look at how that can be supported in the best way possible is the responsibility of general practitioners, whether they do it themselves or not. But as you said, that recognition early that this is someone with pain that isn't normal is so helpful and empowering for that person and puts her on the right track.
I have to come from a naive perspective. I'm a pathologist, so, looking down slides and all kinds of stuff. But how does a woman know what is the appropriate level of pain to be experiencing? Because everyone's experience is tainted by their own experience. So how does a woman or an adolescent woman know that what they're experiencing is actually beyond normal in these instances?
Yes, it's very hard, isn't it? Because how do you compare your pain with someone else's pain? We get back to things that have caused problems for women for forever in the past, of the difference between pain that can be seen, like broken leg or something, and the difference between pain that can't be seen. And so often these things are in that category of pain that can't be seen. So it is a challenge to know what's normal and what's not. I think that the sort of rule of thumbs that I would use is that normal period pain should be not really for more than 1 or 2 days at the beginning of bleeding. And it should be easily managed by simple things like taking a Nurofen or going on the pill or something. It should be easily managed, and that person then leads a normal life. So if you start having pain for more days, if you start having a mix of different symptoms, bowel involved, the stabbing pains of muscle spasm, fatigue, not feeling well, pain that doesn't respond to normal things, or also in people that you actually have a family history of endometriosis or with there's something suspicious, then I think you have to take a lot more notice. And one of the things that's useful is this person missing out on important things in their life? Are they distressed by the pain? Is the pain a significant problem? Or is it something on the first day that's fairly easy managed and not really interrupting her life too much?
Is it essential for a tissue diagnosis to diagnose endometriosis?
No, it's not anymore. So that has been the gold standard. And, I've worked in that area doing laparoscopies for endometriosis for a long time. But once again, we get down to what they mean by endometriosis and also the actual diagnosis. So you can look at endometriosis down a laparoscope, but these days with a high-quality ultrasound, like our South Australian friends at Image Endo are developing, you can actually diagnose a lot of endometriosis from those high-quality scans. But they do have to be a very special endometriosis scan. And through that, they're actually finding quite a lot of women who have endometriosis but very little pain. That gets back to the thing that there isn't a good correlation between the amount of endometriosis and the amount of pain.
How do you distinguish between patients who need laparoscopy and those who don't?
I think that when a girl or woman first comes along, really important to take a careful history of what the issues are. So if she might have period pain, and that's the commonest symptom of the presence of endometriosis, but she's actually likely to have many of a range of other problems as well. So the stabbing pains on the side that go with spasm of obturator internus, the irritable bowel, the food intolerance, the bladder dysfunction, the painful intercourse, which can be aggravated by spasm in the pelvic floor muscles. And then there's all these secondary type central nervous system issues to do with fatigue, poor sleep, anxiety, low mood, nausea, dizzy, faint. So they all can be part of the picture. So if you've got someone that really just has pain with periods, and I'm not saying just because it can be pretty bad, has pain with periods but is otherwise completely well, then I would suggest that management of those symptoms is the most important thing. And you don't necessarily always have to search out and do a laparoscopy. I would only recommend that if you've either got an ultrasound that's suggesting there's a bigger problem or that your treatments aren't working and the period pain is still a big problem. But if she's got a lot of those other symptoms, then I actually think that you need to address many of the other symptoms. You need to manage the period pain, of course, but you need to address a lot of those other symptoms. And even if she does then have a laparoscopy, the whole process will go much more smoothly if those other issues to do with pain, the muscle spasm, the central nervous system, pain sensitization, the bowel and the bladder have been managed beforehand. On the Pelvic Pain Foundation website, we have a page called Tips and Tricks of Recovering Well from Laparoscopy that has all the advice from 3 months before a laparoscopy right through how to prepare, what to ask, how to manage your pain, what to do when you go home, everything from 3 months beforehand to about 6 weeks afterwards to make it a smoother journey. And I think anybody considering a laparoscopy should be looking at that. That will make it so much easier with a much better outcome.
Does the management change of a patient if they're having fertility issues?
If they're having fertility issues, it can do, actually. I think then you look at how likely it is that you think there are actual lesions there. So if there's a family history of endometriosis, if there are more complicated things, it is worthwhile seriously thinking about whether endometriosis is present, because it can change some of the fertility management. So I think that's where a lot of the thoughts are in flux at the moment. It used to be that if you thought there might be endometriosis, you would definitely go to a laparoscopy, tidy that all up first, even if it involved surgery to the ovaries, and then you would see if they got pregnant and talk to a fertility specialist in that area if nothing had happened. The problem with that is that surgery to ovaries can reduce ovarian reserve. So I think this is a complex question of whether to do the laparoscopy first, whether to do the laparoscopy later, and it's really something that fertility specialists tend to have a view on. So I would hesitate to advise on that.
What's the prognosis of a patient with endometriosis like?
For most of them, it's very good. The vast majority of them will get pregnant. It's otherwise the whole condition would have just sort of diminished because no one would have any babies and things like that. So yes, the majority of them will certainly get pregnant. Some of them will have more of a difficult time. And these days, fertility problems are often a mix of conditions. Like there'll be some male factor conditions, maybe some endometriosis, maybe some ovulation issues, maybe some overweight, a whole bunch of things. So fertility is quite complex these days. But the majority of them will be able to conceive. Now, while I said before that there isn't a good correlation between the amount of endometriosis and the amount of pain, there's a much better correlation between the amount of endometriosis and fertility concerns. So somebody who's had a small amount of endometriosis found can really feel good about that because she's less likely to have fertility concerns. So if you have someone with pain who has a laparoscopy and either a small amount of endometriosis or no endometriosis is found, and they've got beautiful ovaries and lovely fallopian tubes and no adhesions and a gorgeous pelvis, you can really say to that person, this is a good outcome. We are still going to manage your pain. We're not going to send you away and discard you or anything. We're still going to manage all the aspects of your pain, but you've got a nice looking pelvis and that's always good and that's always an advantage for fertility.
What management options do you consider that are most useful for patients with endometriosis?
I think you have to think, are we talking the lesions or are we talking the symptoms? And that's what so often doesn't happen. And public doesn't do it and doctors don't do it either. So if we're talking about the endometriosis lesions, the black spots, okay, so you can cut them out or you can suppress them with hormonal suppression. And they're really the two options. There's a variety of hormonal suppression options and there's surgery. Now, what I would say with surgery is that surgery is good at removing lesions, especially if you have a particularly skilled laparoscopic surgeon, not just anybody. But you shouldn't need more than 1 or 2 good laparoscopies in almost all cases to remove the endometriosis lesions. I think one of the problems that happens is whenever people have pain, they think there must be more lesions, they go back and have more surgery. Surgery is a fabulous part of the management of endometriosis, but only to a degree and only for some symptoms. So if your surgeon is skilled, they shouldn't need more than 1, 2, or at the most 3 for something really bad surgeries to remove those lesions. They shouldn't be needing recurrent ones. Now, because also recurrent surgery can worsen pain sensitization and worsen her quality of life and increase her symptoms. I think we've all seen people who've had an operation who are actually worse off pain-wise afterwards. They might have all their lesions removed, but their pain is still an issue. So a couple of good laparoscopies should be as much as is needed if the laparoscopic surgeon is of good quality. Now, if we're managing the symptoms, think of that differently, because the symptoms, some of them might get better with surgery, but many of them go their own path. So they have to be managed in their own way. Remember, at Pelvic Pain Foundation, we consider the symptoms in 4 categories. So firstly, there's the pelvic organ issues, period pain, painful bladder, bowel issues, and, the endometriosis, if it's there. So pelvic issues. Then there's the secondary muscle spasm. And this will be the aching, sharp, stabbing pains that make them want to bend forward, make them love their heat pack, make them want to lie curled up in a ball, not do sport on those days. This is a muscle reaction to what's happening in the pelvis. And this is often the worst pain. In fact, of about half of the people with this that go to an emergency department, if you ask them, what was it that took you to the emergency department? Which pain was it? They will talk about the stabbing pains. They're getting a cramp inside their pelvis. They don't know what it is. It hurts like a cramp. We've all had a cramp. And they're really scared and they don't know what to do. The third thing is the central nervous system. And there's lots of things that can be done to improve that and manage it. And the fourth thing is life disadvantage. So we know that stress and, early adverse life events and difficult lives don't cause these problems, but they do aggravate them. And so if you manage the aspects of the pelvic organs, whichever ones are involved, the secondary muscle reaction, the central nervous system, and as much as you can of the life disadvantage, that's when they get well.
Does endometriosis increase the risk of any other diseases in the long term?
In the long term, often it's the short term. So there are other conditions that are more common. So, for example, migraine is more common in people with endometriosis. I guess by the time you've gone through all those symptoms that I talked about of the food intolerance, the irritable bowel, the et cetera, it's actually associated with a lot of conditions, but a lot of them are things you can't see. So, for example, irritable bowel. The bowel doesn't look abnormal, it behaves badly. I would call it a bit like, naughty children. And just because the ones that look cute aren't necessarily the best behaved ones. So you have to sort of accept that there'll be things you can't see. And a lot of the things that happen to women are things you can't see. That's why they've been so neglected. That's been a situation back since Roman times, when the physicians then, they could understand the broken legs of all those wars that the men went off to, but they had no idea about pain you couldn't see.
Does menopause affect endometriosis?
Well, once again, it depends on whether you're talking the lesions or the symptoms. So if you're talking period pain, well, not getting periods is pretty good for not getting period pain. If you're talking the lesions, then when the estrogen levels fall, they do tend to get more quiet. They don't disappear, but they tend to get quieter and shrivel up a bit and things like that. So the lesions, menopause can certainly settle some things. But if you're thinking about the symptoms, often it depends on how much they've accumulated during their lifetime. So once you've had period pain, etc., for a long time, there are many other aspects of the pain that don't necessarily go away with menopause or even after hysterectomy. So the secondary muscles can have got themselves in a bit of a spiral with the central nervous system and the muscle spasm, and that doesn't necessarily go away when you remove the uterus or cut down the period pain. So some of them get better and others don't. Sometimes there can be a worsening in the 40s because the hormonal levels are so fluctuate so much that they can stir a lot of things up. So I think that it depends on what your patient is coming with. Some conditions, and one I'm thinking of is fibromyalgia, is more common in people who start their lives with bad period pain and who don't have it treated. So untreated pain is really bad for our bodies. It's bad for our central nervous system. It's bad for us. And it can set up things that can persist even if the original period pain stops.
Are there any patients that require long-term specialist follow-up for patients with endometriosis?
I think it depends on the problems that they have. So gynecologists aren't particularly trained in the management of pain. So what are you treating? If your gynecologist is someone who does good surgery and they've removed the endometriosis, if they are somebody who is comfortable managing pain as well, in other words, is comfortable managing the other aspects to it, the non-surgical aspects, then quite possibly that's advantageous. But if your gynecologist is someone who isn't comfortable in that area, then what they need is somebody who is prepared to look at the bigger picture. Whenever we talk about this, we have to recognise just how many people are involved with endometriosis. You know, we've probably got a couple of million, at least 1 million in Australia. So we don't have the workforce to manage all their symptoms. That's the biggest problem. We really need more people, particularly in primary care, to be upskilling in this area and prepared to take on that. That's where general practitioners have a fantastic role. And that's where people like the wonderful Alicia Macrael, who you've got on this podcast as well, she's at the forefront of managing these problems in the community. The gynecologists have a surgical role when that's involved, and then it depends on whether they've chosen to upskill or they haven't. But it's the general practitioner that sees these people long term and has the difficult management of some of these things. But with so many people affected, workforce is the biggest issue, and everybody has a role.
Yes, and that's grim across many sectors in Australia, and it's obviously at the sharp end in this situation. Susan, you're involved in research and treatment of pelvic pain in women as CEO of Alira Biotech, the biopharmaceutical company here in Adelaide. I'm curious to know if there are any therapies that are showing promise that might be available in the near future.
Well, the reason I did a PhD in the neuroimmune basis of endometriosis, period pain and pelvic pain is because basically the answer's been no. So that's why I decided to study it. I said you can give great care to a tiny number of people, but we don't have enough tools in our toolbox to manage all these things. We don't have enough workforce, which is why I founded the Pelvic Pain Foundation of Australia for practical support to practitioners. And we don't have enough tools to actually manage these things, let alone the central and immune basis for pain. So the answer is no. There are some newer options for hormonal management. One of them is the Raico, the GnRH antagonist mixed with hormonal things to improve that. I think that's going to make life easier for some people who are using hormonal suppression. But it's another hormonal medication. So while I'm fully supportive of its introduction in Australia, the hormones and the surgery can only go so far. And one of the reasons why so many women are unwell and unhealthy is that we haven't got more, we haven't got better things. So the research around the world is in the pain, central nervous system, and immune inflammation space. And that's what we're doing at Alira. So we're developing a intrauterine device to turn down the excess immune activation in the uterus, which is sensitizing the body, including the central nervous system, so that we can pick people early that have got this bad period pain and stop it causing all these additional symptoms in the central nervous system and the secondary muscle spasm and those things. So the answer is, once you get past hormones and surgery to the things that really reduce quality of life, sadly, the answer until we do something is no.
On the note of picking things up early and connecting with women early, there is one other program that was mentioned in the introduction, and that's the thing called Pep Talk,
Yes.
which is a program that the Pelvic Pain Foundation of Australia provides to our high schools here in Australia. Can you elaborate a little more on that? What's involved?
Yes, I'd love to. Because even though I was a bit gloomy saying you wanted new treatments, like something novel and new, there's lots that can be done in this space, and general practitioners are perfectly placed to do them. So there's lots of things. If we've got time, I can go through some of those. But the Pep Talk program is just a joy. So we have educators, all have a health qualification of some kind, who we train up ourselves, who go out to the schools and talk to students. And we have, of course, most of their sessions are for 15, 16-year-old girls in schools, but we also do sessions for boys, we do sessions for sporting clubs, for coaches, for workplaces, and for in practitioners in their practices to help upskill them. So we're out there trying to build pain education, put students on the right path, and upskill practitioners. So Pep Talk it's fun, it's interactive, the students love it. 100% of the schools we go to want us to come back. And we are in every state to a variable degree. We started in South Australia. We've been here 5 years now. And it is always a joy to work with young people and know that what we're doing is putting them on a path to less pain.
There is one thing I want to touch on, because we've mentioned it a few times, but I also want to sort of direct our listeners probably to this area. You've mentioned the Pelvic Pain Foundation of Australia. Can you tell us a little bit about that and how people can find out more about that?
It was recognised, I think back, it was about 2011 or so. I went to a national pain summit in Canberra, and it had representatives from all the different pain groups. And I was there, and there was nothing about women's pelvic pain. There was nothing about endometriosis. Women were like a non-thing. There was everybody else you can imagine. And it was just so obvious that there was no advocacy body for pelvic pain. No one was out there in the not-for-profit sector caring for this massive group of Australians. So I thought about it for a while, and then I got together with a lawyer, an accountant, and another pain medicine physician, and we decided things would change. So we launched in 2015 with Pelvic Pain Foundation of Australia here in Adelaide, and we have a website which has loads of information, which should be the go-to for any person with pain or practitioner. And we've got lots of information, including that sheet I talked about what to do if you're going to have laparoscopy. And we've always cared for both sides of the consultation desk. We care for health practitioners as well, because we know it's not easy. It's not easy seeing people with difficult pain when you haven't got everything you need to help them. So we run a health practitioner seminar in Adelaide every year to help people build teams and learn new aspects of practical management of pain. Our next one is August 31st in Adelaide this year, but we have one every year and the practitioners love it. We have subscriber sessions for practitioners that want to learn more, and we have lots of resources and information. To make a difference in Australia, we have to look at free or low-cost solutions for people and practitioners, no matter where they live and their socioeconomic circumstances. A patient at the moment cannot expect to go to a practitioner and be fixed and be sort of done to. In other words, here I am with my pain with 10 different symptoms and you're going to fix me. It has to be both ways because we don't have all the things we need yet to fix that person like we're used to in medicine, fixing them. They need to learn more. So they need to do things like go to the pelvicpain.org.au website, learn more about pain. We've got a section for each type of person and what their needs are. Learn more about the different treatments that are available, the things they can do themselves, the things they can do for free, how to be more active in working with their practitioner, and that's how they make great progress. So we've got lots of things for them. We've got ideas, no medication options, how to understand medications. I wrote a book many years ago, which still seems to be, people seem to read, and I have one for teens coming out later this year. So I think it was to help both sides of the consultation desk come together, an educated patient group and an upskilled workforce. We welcome anyone with an APRA number.
Look, that's excellent and inspirational. Just before my last question, I know we've only just met, but I have formed a nickname for you. It is Associate Professor Susan Lesions or Symptoms Evans.
Oh, I'll go for that. I'll go for that.
Good. Look, Susan, this is my final question. Any final thoughts or comments for doctors, GPs, or even patients about pelvic pain and endometriosis? Closing thoughts.
Well, for your practitioners, I'd really like to say that doesn't need to be disheartening, that when you actually do treat someone's pain and they come back and their life is so much better, it's some of the most gratifying work in medicine. I know Alicia knows that. And you really can make the difference to a young person and change their life. So we welcome you. We'd love to meet you. And thanks for taking the time to listen.
And thank you, Associate Professor Susan Evans. This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.